So a lot of drugs can actually cause type 4 renal tubular acidosis. Now we just saw that a few kidney diseases can also cause type 4 renal tubular acidosis. What are they? CKD, diabetic kidney disease, then you have obstructive uropathy, and patients who are going to have lupus nephritis. So 4 major causes as far as the renal diseases are concerned for type 4 renal tubular acidosis. One of the most common causes is going to be diabetes. Now a lot of drugs can cause type 4 renal tubular acidosis. So as I said, 3 major contributors: aldosterone, the collecting duct, and the ENaC channel. So any reduction in aldosterone synthesis like ACE inhibitors, reduction of aldosterone release like NSAIDs, heparin, any reduction of binding of the aldosterone to the receptor, aldosterone receptor antagonists like spironolactone and eplerenone, any inhibition of the ENaC channel like amiloride, trimethoprim, pentamidine, and inhibition of basolateral sodium potassium ATPase activity and mineralocorticoid receptor expression like which is seen with use of calcineurin inhibitor. So these are all the different drugs which can cause type 4 renal tubular acidosis. So whenever you have type 4 renal tubular acidosis, remember that your patient could be on ACE inhibitors, your patient could be a diabetic, and your patient could be having an obstructive uropathy. Or the patient could be on some mineralocorticoid receptor antagonists like spironolactone, eplerenone, or ENaC channel inhibitors like amiloride. So remember aldosterone, and when aldosterone is blocked, that could happen from ACE inhibitors or mineralocorticoid receptor antagonists. Remember ENaC channel and ENaC channel inhibitors can result in type 4 renal tubular acidosis. As far as the renal diseases are concerned, the important ones to remember are diabetes and obstructive uropathy. Now whenever you have this combination of hyperkalemia and acidosis, what else will you think for? Other differentials are going to be aldosterone deficiency and actual hypoaldosteronism. It could be a pseudo hypoaldosteronism where there is going to be a loss of function mutation in the ENaC channel or mutations in the family of kinases, WNL family of kinases. And finally, there could be aldosterone resistance at the kidney, which can be seen in patients with sickle cell nephropathy. So all these can also cause hyperkalemia with acidosis: true hypoaldosteronism, pseudo hypoaldosteronism, and sickle cell nephropathy. Now, having understood the basics of type 1 distal RTA, acid secretion defect, type 2 proximal RTA, bicarbonate reabsorption defect, and finally you have type 4, which is hyperkalemic RTA, which is because of a defect primarily in potassium secretion at the level of the collecting duct. These are the 3 major types of RTA. Now let's try to understand a bit about their diagnosis and management before we wrap off this session. Now these are the indicators which will help us to understand what is the type of renal tubular acidosis we are dealing with. So if potassium is low, if there is osteomalacia, there is no nephrocalcinosis, if the urine citrate is normal, and if the urine ammonium is normal or low. So variable. This picture. So whenever you have a picture with hypokalemia, normal, all these patients have a normal anion gap metabolic acidosis. So these patients are also going to have osteomalacia as they've described. But they don't have nephrocalcinosis, they do not have any hypocitraturia, they do not have any hypercalciuria. That means here we are looking at a proximal renal tubular acidosis. And look at the pH. The pH is variable. It can vary from 5.2 to 7. So this broad range of pH is possible only in patients with proximal renal tubular acidosis. Remember, in the early stages of proximal renal tubular acidosis, bicarbonate, serum bicarbonate will relatively be preserved, therefore your urine pH will be less acidic, more alkaline. But as the disease progresses, what happens? The serum bicarbonate drops and therefore these reabsorptive mechanisms become active again, resulting in an acidic urine. So whenever you have an acidic urine in patients with proximal renal tubular acidosis, that usually indicates a late stage of proximal renal tubular acidosis, and bicarbonate hardly falls below 16 in these patients. Now when you have a urine pH which is not so variable, often alkaline, always above 5.5. Now that's not the case with proximal renal tubular acidosis. In proximal renal tubular acidosis, the urine pH is going to depend on how old the disease is, on the disease duration, and how bad the bicarbonate is. The lower the bicarbonate, the urine pH tends to be lower. Now with distal renal tubular acidosis, you find that the urine pH is going to be always above 5.5. There is a defect in the urine acidification. So the urine is never acidic. It is always less acidic and more alkaline. Potassium is low. Osteomalacia here again is going to be present, but nephrocalcinosis is present, hypocituria is present, urine ammonium is low. So there is an acid secretion defect. Here we are talking about distal renal tubular acidosis. And then finally we have patients whose urine pH can be acidic, less than 5.2, with potassium which is strangely and surprisingly on the higher side. With osteomalacia being absent, no hypercalciuria, no hypocituria, no nephrocalcinosis or nephrolithiasis. Urine ammonium however is low. Why is the urine ammonium low here? Because here we know that primary problem is with potassium secretion. There is a potassium secretion defect, but that is going to give rise to a hydrogen secretion effect, because this is going to impair ammonia production at proximal tubule, and that is going to indirectly affect hydrogen secretion. So there is a potassium and a hydrogen secretion defect. So the patient has hyperkalemia and an alkaline urine and a metabolic acidosis. So this is your type 4 renal tubular acidosis. So a quick fix approach to renal tubular acidosis: whenever you have a normal anion gap metabolic acidosis, whenever you have this picture, now this means there is either a bicarbonate loss or a hydrogen ion retention. And now this could occur either at the kidney level or this could occur at the level of the gastrointestinal tract. So bicarbonate loss can be either renal or extrarenal. And what are the important extrarenal causes of normal anion gap metabolic acidosis? Renal cause is going to be renal tubular acidosis. Extrarenal cause is going to be chronic diarrhea or chronic laxative abuse. So that is going to result in GI washout of bicarbonate, resulting in a normal anion gap metabolic acidosis. So usually what do you do when you have a normal anion gap metabolic acidosis? You do a urine anion gap. Now what is a urine anion gap? Urine anion gap is nothing but the in the urine you take the sum of the cations, sodium and potassium, minus the anion, which is chloride. So this is going to give you a urine anion gap. Now this urine anion gap is normally 0 to 10. Now remember, lower the urine anion gap, that means there is a lot of ammonium in the urine. Higher the urine anion gap, that means there is very less ammonium in the urine. We are talking about ammonium in the urine, ammonium secretion in the urine. So this is how the urine anion gap correlates with acid secretion. So higher it basically correlates inversely with acid secretion in the urine. Higher the urine anion gap, that means there is very less acid secretion in the urine. So usually when you do a urine anion gap, it is going to be normal, reflecting a normal acid secretion in the urine in extrarenal causes. So when you have a normal urinary anion gap, you are looking at chronic diarrhea and chronic laxative abuse. These are the things you will rule out. So when you have a normal anion gap metabolic acidosis, you do a urine anion gap. If the urine anion gap is going to be more than 20, you are looking at renal tubular acidosis. If it is going to be normal between 0 to 10, we will have to rule out diarrhea and laxative abuse. Now, if the urine anion gap is going to be high, you look at the serum potassium, because you are looking at renal tubular acidosis. If the potassium is high, then you automatically know you are dealing with a type 4 renal tubular acidosis. Now, in type 4 renal tubular acidosis, we just discussed the problem could be either with aldosterone or the problem could be with the kidney, like in diabetic kidney disease or obstructive uropathy, where there is a problem in the cortical collecting duct cell itself. So, how do you know this? So, basically you look at the urine pH. When you look at the urine pH, and if the urine pH is going to be acidic, if it is going to be less than 5.5, that means there is a problem only in the aldosterone. That's why the urine pH is normal. So, it is not a tubular dysfunction, it is only problem with the aldosterone. Whereas, if the urine pH is alkaline, then you are likely looking at a defect in the collecting duct. Now, if the patient has a normal potassium, here what do? You look at the urine pH. If the urine pH is going to be less than 5.5, that means this patient has a renal tubular acidosis of renal insufficiency. Sometimes in patients with chronic kidney disease, in earlier stages when they have not developed hyperkalemia yet, they can have this phase of normal potassium levels with an acidic urine with a normal anion gap metabolic acidosis. So, that is what we are referring to here. Then finally, when your patient has hypokalemia, then what are you going to do? You have two possibilities. Either you could be looking at a distal renal tubular acidosis or a proximal renal tubular acidosis. So, one easy way to delineate between the two would be to look at the proximal renal tubular function and to look at the presence of hypercalciuria, nephrolithiasis and nephrocalcinosis. If proximal renal tubular dysfunction in the form of hypophosphatemia, hypouricemia, aminoaciduria, glucosuria, if these are all present, then you are looking at proximal renal tubular acidosis. If proximal tubular function is normal and if the patient is having nephrolithiasis, nephrocalcinosis and hypercalciuria, then your urine pH is alkaline, you are looking at distal renal tubular acidosis. If there is a diffuse proximal renal tubular dysfunction with urine pH being variable, then you are looking at proximal renal tubular acidosis. So, this is a quick approach. Now, here at this point, there are two other important tests which will help us in differentiating whether it is type 1 or type 2 renal tubular acidosis, because often there can be a lot of overlap. Sometimes patients with distal renal tubular acidosis need not always present with nephrolithiasis, nephrocalcinosis and hypercalciuria. So, in that case, there may be a lot of confusion. So, what are these tests which are going to help? One is the ammonium chloride loading test and the other is going to be the sodium bicarbonate loading test. Now, before understanding them, a little bit about urine anion gap, which I already mentioned. Now, first step is this plays an important role in identifying whether it is a renal cause of normal anion gap metabolic acidosis or whether it is an extra renal cause. So, if urine anion gap is high, if it is more than 20, you are looking at renal tubular acidosis. If it is normal, if it is between 0 to 10, you are looking at either chronic diarrhea or laxative abuse. This is how you calculate urine anion gap. One very important detail as far as the urine anion gap is concerned is that this is valid only if the urine sodium is above 20. If the urine spot sodium is below 20, then the urine anion gap measurement is not valid. So, for you to actually start calculating urine anion gap, the prerequisite, most important prerequisite is that the urine sodium should be at least 20 milliequivalent per liter. Now, what is this ammonium chloride loading test? So, basically you load the patient with an acid which is ammonium chloride and then you actually see whether the patient is secreting this acid in the urine or not. So, when you give the patient this acid, what happens to a patient with type 1 renal tubular acidosis? Here there is a problem with acid secretion, right? So, even when you give the acid, you will find that the urine pH is still above 5.5. Whereas, in type 2 renal tubular acidosis, because here the problem is a base a reabsorption defect. There is a bicarbonate reabsorption defect and no problem particularly with acid secretion. Giving the patient ammonium chloride will decrease the urinary pH to less than 5.5. So, this is number 1. The second finding from this oral ammonium chloride test is that when you do a urine anion gap following administration of ammonium chloride, the urine anion gap is going to be less, reflecting a good ammonium chloride secretion in the urine in patients with proximal renal tubular acidosis, whereas the urine anion gap is going to be high, reflecting a poor ammonium chloride secretion in urine with patients with this acid secretion defect which is seen in type 1 renal tubular acidosis. So, very simple. So, when you do a acid, this is an acid loading test. So, the defect which is going to impair acid secretion, that is not going to perform well. Therefore, in distal renal tubular acidosis, even as you keep loading the patient with this acid called ammonium chloride, the urine pH does not alter. It still remains alkaline. It still remains above 5.5 and your urinary anion gap is going to be high. Whereas in proximal renal tubular acidosis, your urine pH drops down to below 5.5 because this acid gets secreted in the urine and your urine anion gap is low, reflecting this process. In the sodium bicarbonate loading test, what happens? We give the patient this alkali called sodium bicarbonate and then, so what you basically do is, this is because sometimes when the patients, I already told you, when the bicarbonate drops down to very low levels, So what happens? The urine pH, these reabsorptive mechanisms start working. Therefore, deceptively the urine pH is going to appear relatively more acidic in patients with advanced proximal renal tubular acidosis. So, to circumvent this problem, you are going to give the patient more alkali, push this bicarbonate up so that you cross that threshold and then see how the bicarbonate reabsorption is. So, once you increase this bicarbonate above the threshold, then you will find that there is a defect in renal tubular bicarbonate reabsorption at the proximal tubules. So, you will find that in patients with proximal renal tubular acidosis, with bicarbonate loading test, the fractional excretion of bicarbonate, which should have been less than 5%, increases to above 15%, and the urine pH, which was initially less than 5.5, usually increases to above 7.5. So, very, very important. So, distal renal tubular acidosis versus proximal renal tubular acidosis, that is where ammonium chloride test is going to come in handy. Whereas, when you take the bicarbonate loading test, this is going to help to confirm a diagnosis of proximal renal tubular acidosis, particularly in patients with advanced proximal renal tubular acidosis with low bicarbonate and low urinary pH. So, this was where we already arrived at, right? This bit of the approach we already saw. We saw that in normal anion gap metabolic acidosis, you do a urine anion gap. If the urine anion gap is going to be high, then you are looking at renal tubular acidosis. If the urine anion gap is going to be normal 0 to 10, then you are looking at a GI cause like laxative abuse or chronic diarrhea. Now, if urinary anion gap is high, it's renal tubular acidosis. You look at the potassium. If potassium is high, it is type 4 RTA. Depending on the pH, you know if it is an aldosterone defect or a collecting duct defect. Similarly, if the potassium is low, you will know that this patient either has a type 1 RTA or a type 2 RTA. You look for features of hypercalciuria, other features of proximal tubular dysfunction, and to differentiate between the two, ammonium chloride loading test will be helpful. With ammonium chloride loading test in distal renal tubular acidosis, the urine pH still remains above 5.5 and the urine anion gap will be high. This is not the case with type 2 renal tubular acidosis. Further, to confirm this, you do a sodium bicarbonate loading test, where in that test you find that the fractional excretion of bicarbonate is going to be more than 15% and the urine pH increases to above 7.5 with alkali loading. So, this is the primary role of these tests. So, in patients further with type 4 renal tubular acidosis, you can also do a transtubular potassium gradient following a mineralocorticoid administration, and when you give a mineralocorticoid and when that demonstrates good potassium excretion, then that tells you that your kidneys are performing well and there is a problem only with the mineralocorticoid axis. But following mineralocorticoid administration also, if potassium excretion is impaired, then that tells you then there is a problem in the kidney, not with the aldosterone level. So, this is what we already saw. Quickly, let's try to understand the basic principles of management in renal tubular acidosis. Alkali therapy, either in the form of sodium bicarbonate or potassium bicarbonate, is recommended, usually given at 1 to 2 millimoles per kg per day for distal renal tubular acidosis. Now, potassium citrate is going to be the preferred agent for proximal renal tubular acidosis, given at a dose of 10 to 15 millimole per kg per day. Now, proximal renal tubular acidosis is what requires large doses of alkali, and we'll also have to address other electrolyte disturbance and we'll have to correct the vitamin D when we are managing proximal renal tubular acidosis. Now, what are the adverse effects? Adverse effects include bloating, belching and gastrointestinal intolerance. Now, type 4 renal tubular acidosis, here what do? We give them potassium binders to reduce the potassium. We can even give low dose fludrocortisone or sodium bicarbonate and loop diuretic combination. And these hydrogen binders called Veverima, this is a new drug which is currently under research to promote hydrogen secretion in the urine in patients with renal tubular acidosis. So, overall, as we wrap this session on renal tubular acidosis, let's try to quickly recall, compare and contrast the important features of each one of these three types. So, type 1 acid A, type 1A acid secretion defect. So, remember, in addition to acid secretion defect, here both in type 1 and type 2 there is going to be normal anion gap metabolic acidosis, there is going to be hypokalemia, that is common to both, and type 2 is because of B, bicarbonate reabsorption defect. So, between the two, which is different? In distal renal tubular acidosis, there is also going to be hypercalciuria and hypocytituria, which promotes nephrolithiasis and nephrocalcinosis. Now, this is not seen in proximal renal tubular acidosis. In proximal renal tubular acidosis, you may have other features of proximal tubule dysfunction like glucosuria, aminoaciduria, uricosuriya, phosphaturia, all this can be there. However, in both distal and proximal renal tubular acidosis, you can have osteomalacia. In distal, it is going to be because of hypercalciuria, and in proximal, it is going to be because of phosphaturia. Hyperkalemic renal tubular acidosis, here this is a hyporeninemic hyperkalemic renal tubular acidosis. There is a problem in potassium secretion at the level of the cortical collecting duct, and hence that translates into a problem in the hydrogen secretion as well. And here patients are usually asymptomatic. Now, when you take distal renal tubular acidosis, just two important causes remember, it could be hereditary or it could be because of drugs like amphotericin B or diseases like Sjogren's and SLE. Similarly, when you take proximal, this could be primary hereditary or it could be part of Fanconi syndrome where there is going to be a diffuse proximal renal tubular dysfunction. Now, Fanconi is common in most common causes multiple myeloma. Other storage diseases like tyrosinemia, galactosemia can all cause Fanconi syndrome. And hyperkalemic type 4 renal tubular acidosis, here the most common causes are going to be either problem in the kidney like diabetic nephropathy or obstructive uropathy, or there could be drugs implicated, drugs which affect aldosterone or eNaC channels like amiloride or mineralocorticoid receptor antagonists like spironolactone and eplerenone. Now, when you take urine pH in distal renal tubular acidosis, it is going to be usually above 5.5. In proximal renal tubular acidosis, it is going to be variable, and in hyperkalemic renal tubular acidosis, here again it is going to be acidic, usually less than 5.5. Serum bicarbonate is usually very low in patients with distal renal tubular acidosis, but in proximal renal tubular acidosis and hyperkalemic renal tubular acidosis, it is relatively preserved above 16. Serum potassium is going to be low in the first two types of renal tubular acidosis and high in the type 4 renal tubular acidosis, and urine anion gap is going to be increased in patients with renal tubular acidosis. However, remember that I am only talking about the urine anion gap. When you look at the serum anion gap, that is going to be normal across all three types of renal tubular acidosis. Now, as I mentioned, an ammonium chloride loading test is something that's used to differentiate between distal and proximal renal tubular acidosis. Usually following loading with an acid, the urine anion gap increases in patients with distal renal tubular acidosis and the urine pH remains above 5.3. Whereas when you take proximal renal tubular acidosis, here the patients do not have a high urine anion gap after ammonium chloride loading test, and the urine pH is going to decrease following the ammonium chloride loading test. Further, when you do a sodium bicarbonate loading test, the fraction excretion of bicarbonate is going to increase and the urine pH is going to increase. And when you take hyperkalemic renal tubular acidosis, here you will find that the potassium is high, the patient has a normal anion gap metabolic acidosis, and then you can also look at the urine pH, which is going to be variable depending on where the defect is, and the post-fluorocort TTKG will tell you whether the defect is in the kidneys or whether the defect is in the aldosterone axis. And how do you manage these patients? Distal renal tubular acidosis patients, you will have to advise them to increase the intake of alkalis, increase citrus fruits, restricted sodium intake, normal calcium intake. And then what do? You can put them on alkylating agents like sodium bicarbonate or potassium bicarbonate. Now, in patients with proximal renal tubular acidosis, these patients are going to require large doses of alkali therapy, usually preferred agent being potassium citrate. So, with distal renal tubular acidosis, you can use either sodium or potassium bicarbonate, whereas here in proximal, the preferred agent is going to be citrate. It is going to be potassium citrate. You will also have to address other electrolyte imbalance and correct the vitamin D. And in type 4 renal tubular acidosis, the main line of management is in the form of potassium correction, potassium binders. Sometimes if the problem is with mineralocorticoids, low dose fludrocortisone will also be helpful. So, with this we come to the end of our session on renal tubular acidosis. So, remember, whenever you have a normal anion gap metabolic acidosis, then what do? You look at the urine anion gap. When you look at the urine anion gap, if the urine anion gap is elevated, then you are looking at a renal tubular acidosis. If the urine anion gap is normal, then you are looking at a GI cause like chronic diarrhea or a laxative. When you are looking at a renal tubular acidosis, if your patient has a high potassium, then you are looking at type 4 renal tubular acidosis. So, in these patients, the best thing to do is you do a post-fludrocort TTKG. when you do post-fluid record TTKG, if your potassium increases, that means the problem is in the aldosterone. So, this is an aldosterone defect. If the potassium secretion does not increase, then problem is in the collecting duct. So, this is how you localize the defect. Similarly, here what happens if your potassium is low, what are you going to do? You are going to look for features of hypercalciuria, nephrocalcinosis, nephrolithiasis, no features of proximal tubular dysfunction. If this is the picture, then you are looking at distal renal tubular acidosis. So, how do you confirm? You do a ammonium chloride loading test. On the ammonium chloride loading test, your urine anion gap should be elevated and the urine pH continues to be above 5.5 despite acid loading. On the other hand, there is no hypercalciuria. There are other features of proximal tubular dysfunction. There is hypophosphatemia, hypouricemia, aminoaciduria, glucosuria. So, in this case, you do a sodium bicarbonate loading test to confirm the diagnosis. When you do this, you will find that the fractional excretion of bicarbonate will increase to about 15%, and you will also find that the urine pH has become extremely alkaline, above 7.5. So, that tells you are looking at proximal renal tubular acidosis. And with this, we have come to the end of our discussion on renal tubular acidosis. Thank you. I hope this has been helpful. This is Dr. Adhiti for RAAONLINE.